Imagine this. Your heart stops. Doctors rush in. They could save you. But there's a bracelet on your wrist that says, don't. This isn't science fiction. This is a choice millions of people make every single day. And what happens next might surprise you. A 78-year-old woman lies in a hospital bed. Her heart flatlines. The monitor screams. Nurses burst through the door. But then they stop. They look at her chart. DNR. Do not resuscitate. They step back and watch her die. Her family is sobbing in the hallway, begging them to do something, anything, but the doctors can't. She made her choice 6 months ago when she was healthy, thinking clearly, imagining a peaceful end. Now that moment is here, and there's no going back. This is the reality of DNR orders. A legal document that stands between you and the most aggressive life-saving intervention that modern medicine can offer. CPR. But here's what nobody tells you when you're signing that paper. CPR isn't what you see on TV. DNR isn't giving up. And the choice between them? It's way more complicated than life or death. What actually happens during CPR? Let's start with what CPR really is, because Grey's Anatomy lied to you. When your heart stops, you have minutes before brain damage becomes permanent. CPR, cardiopulmonary resuscitation, is the emergency procedure designed to manually keep blood flowing to your brain and organs until your heart can be restarted. Here's what actually happens. A doctor or paramedic places their hands on your sternum and compresses your chest. Hard. We're talking pushing down 2 inches with enough force to break ribs. And yes, ribs break frequently during CPR. You'll hear them crack. It sounds like stepping on bubble wrap, except it's someone's bones. They compress 100 to 120 times per minute. That's nearly twice per second, for minutes. Sometimes for over an hour. Between compressions, someone is forcing air into your lungs with a bag valve mask or breathing tube. Your chest rises and falls artificially. Meanwhile, another team member is trying to inject drugs into your veins, epinephrine to shock your system, medications to stabilize your heart rhythm. If your heart won't restart, they use defibrillator paddles. You've seen this in movies, the dramatic clear, and the body jolting off the bed. In reality, it's more controlled, but the electricity coursing through your body is very real. Sometimes they insert breathing tubes down your throat. Sometimes they cut into your chest for open cardiac massage, literally squeezing your heart with their hands. Sometimes they put you on ECMO, a machine that pumps and oxygenates your blood outside your body. It's medieval and miraculous at the same time. Now here's the part that medical dramas skip. CPR has terrible success rates. In hospitals, only about 25% of patients who receive CPR survive. Outside hospitals, it drops to 10%. And surviving doesn't mean walking out fine. Many survivors have broken ribs, brain damage from oxygen deprivation, damaged organs, or spend the rest of their lives on ventilators in nursing facilities. The Hollywood version where someone gets CPR and wakes up perfectly fine? That happens in less than 3% of cases. But here's the thing, that 3% exists. Some people do survive, some people get their lives back. Some people get to see their grandchildren graduate, take one more vacation, have one more Christmas. CPR can be the miracle. It can also be the nightmare, and that's exactly why DNR orders exist. Understanding DNR, it's not just letting someone die. DNR stands for Do Not Resuscitate. It's a medical order that tells healthcare providers, if my heart stops or I stop breathing, do not perform CPR. Do not intubate me. Do not try to restart my heart. Let me go naturally. But here's what DNR is not. It's not a suicide note. It's not refusing all medical care. It's not pulling the plug. A person with a DNR order can still receive antibiotics, pain medication, oxygen, fluids, dialysis, chemotherapy. Basically every medical treatment except the specific interventions that restart your heart or breathing after they've stopped. Think of it this way. DNR is about deciding how you want your final moments to go if your body is shutting down. It's saying, I don't want my ribs broken and my chest compressed while I'm dying. I don't want a breathing tube forced down my throat. I don't want to be shocked with electricity. I want to die peacefully with my family, not surrounded by a trauma team. People choose DNR for different reasons. Some have terminal illnesses like advanced cancer or end-stage heart failure. They know death is coming soon regardless, and they'd rather die comfortably than endure aggressive interventions that will only extend suffering by days or weeks. Some are elderly and have lived full lives. They've watched friends go through brutal resuscitation attempts that left them in vegetative states. They don't want that. Some have religious or philosophical beliefs about natural death. Some simply understand the statistics and decide the odds aren't worth the trauma. And here's something crucial. You can have a DNR and still want to live. This confuses people. A DNR isn't about wanting to die. It's about accepting that if your heart stops, if you reach that final moment, you want to go peacefully rather than fighting a battle you probably won't win. And even if you do win, you might not recognize the life on the other side. The gut-wrenching gray areas. Now let's talk about where this gets messy, because medicine is never black and white. A 45-year-old man with a DNR gets in a car accident. He's bleeding but conscious. He needs surgery. The hospital operates. But during surgery, his heart stops. The anesthesiologist looks at the DNR order. What now? The heart stoppage isn't related to his underlying condition. It's a surgical complication. Do they honor the DNR and let him die? Or do they perform CPR because this is a reversible emergency situation? Different hospitals have different policies. Some honor DNR orders absolutely, no exceptions. Some have clauses for reversible causes, where they'll intervene anyway. Some require patients to specify DNR even during surgery separately. The man's family is in the waiting room thinking he's getting a routine operation. They have no idea he's dead because of a form he signed. Or, consider this. An 80-year-old woman with dementia has a DNR. She doesn't remember signing it. Her heart stops. She's clearly struggling, gasping. Every instinct screams to help her, but the paper says, don't. The nurses stand there watching her die, following her own orders that she no longer understands or remembers making. Is that mercy? Or is that abandonment? Here's another nightmare scenario. A patient has a DNR. Their heart stops. The family rushes in screaming, "Save them! Do something!" They're threatening to sue. They're physically trying to start CPR themselves. But legally, the DNR stands. Medical staff have to physically restrain family members while their loved one dies. The family will hate them forever for letting them die. But performing CPR would be assault, literally. The patient said no. Then there's the opposite problem. A patient wants full resuscitation. They want every possible intervention. But they're 95 years old with multiple organ failure. The doctor knows CPR will break every rib, rupture organs, cause brain damage, and the patient will die anyway, just after days of agony instead of peacefully. Should the doctor perform CPR because the patient requested it, or refuse because it's medically futile and harmful? Some states allow doctors to write unilateral DNR orders, overriding patient wishes when intervention is deemed futile. Other states legally require attempting CPR if the patient wants it, no matter how pointless. There's no consistency. Geography might determine whether your wishes are honored. The conversation nobody wants to have. Here's the brutal truth. Most people never think about this until it's too late. A study found that 90% of people say they want to discuss end-of-life care with their doctors, but only 30% actually do. Why? Because talking about your death is uncomfortable. It feels morbid. It feels like giving up. Families don't want to have the conversation because it feels like planning someone's death while they're still alive. So what happens? People end up in hospitals, suddenly facing these decisions in the worst possible moment. Your dad is in the ICU, unconscious. The doctor asks, "Do you want us to resuscitate him if his heart stops?" You have 30 seconds to make a choice that will haunt you either way. You don't know what he would want. You never asked, nobody asked. And now you're deciding whether he lives or dies based on a guess. Or worse, there's family conflict. Mom has a DNR, but your brother refuses to accept it. He insists she would want to fight. You're honoring her wishes. He's screaming that you're killing her. Now you're not just losing your mother. You're destroying your family over a decision she could have clarified if everyone had just talked about it openly. The answer isn't simple, but the conversation is necessary. Talk to your family. Talk to your doctor. Not when you're dying, but now. When you're healthy. When you can think clearly. Ask yourself, If my heart stops, do I want someone breaking my ribs trying to restart it? Under what circumstances? Would it matter if I was 40 versus 90? Would it matter if I had terminal cancer versus being otherwise healthy? And make it official. A conversation isn't legally binding. Get a real DNR order or an advance directive. Make sure your family has copies. Make sure your doctor has a copy. Make sure it's in your medical records. Wear a medical alert bracelet if you have a DNR. Paramedics can't check your paperwork while you're dying on the sidewalk. The uncomfortable truth. Here's what nobody wants to say out loud. Both choices can be wrong. Choosing CPR might mean dying in agony, breaking bones, suffering brain damage, spending your final days intubated and unconscious. Choosing DNR might mean dying when you could have survived, when one more day could have meant everything, when the odds were against you, but you could have been the miracle case. There is no perfect choice. There's only your choice. And making no choice? That's still a choice. It just means someone else will make it for you in the worst possible moment under the worst possible circumstances. DNR versus CPR isn't really about life versus death. It's about what kind of death you want if death is coming anyway. It's about dignity versus hope. It's about accepting mortality versus fighting until the very end. And it's about having the courage to think about the unthinkable while you still can. So think about it. Talk about it. Decide. Because someday someone will be standing over you, hands ready to compress your chest, and they'll be looking for an answer. Make sure they have one,